Good evening, everybody. Welcome. Thanks, everyone, for coming to this evening's presentation. My name is Bob Doyle. I'm the Executive Director of the Colorado Tobacco Education and Prevention Alliance. I'm also Chair of Colorado SAM, Smart Approaches to Marijuana, a new statewide coalition. And it's really my work in tobacco prevention over the last 20 years plus that brought me to the marijuana issue about 3 years ago. I will be the moderator this evening. We have an excellent panel. We have each panelist speaker will be about 20 minutes, and then we will have question and answer at the end. So you'll see me at the 15-minute mark raise my hand. That's not waving to you all. It's just warning them they have 5 minutes to go. Tonight's presentation is on the science of marijuana. This should be a very informative discussion, and it's hosted by the Arise Network and CeDAR. So without further ado, I want to get to our speakers this evening. And each of them has a bio that could take the full hour and 20 minutes, but I've shortened them considerably. So let's start with our first speaker is Dr. Judith Landau. She is a child, family, and community neuropsychiatrist and former professor who has spent many years studying resilience and overcoming adversity. Co-developer of the evidence-based best practice Arise Continuum of Care, Dr. Landau draws 30 years of research experience aimed at facilitating long-term healing for addicted individuals and their families. Author of over 200 publications, she has taught in more than 100 countries, trained more than 2,000 certified Arise interventionists, been principal investigator on research conducted through WHO, NIDA, NIAAA, and has consulted to UN, WHO, NIMH, NIDA, NIAAA, SAMHSA, and several international governments. Currently, she is recognized as a global addiction and trauma pioneer. Please welcome Dr. Landau.
Good evening. So I will be...
Use the microphone.
Thank you. They want to hear as well. Thank you. Let's see if this clicker is working. Great. So I'm going to be talking about awareness, prevention, and intervention and what families can do. So despite changes in the law, marijuana is a highly addictive substance, posing serious threat to users. Its use is becoming more culturally accepted, but as we've learned from our experience with alcohol, that doesn't mean that the dangers are reduced. Today's strains of cannabis and synthetic products like spice are up to 20 times more powerful than strains tested a decade ago because they include dangerously high levels of tetrahydrocannabinol, commonly known as THC. What is really concerning to us is that today's strains have been found to result in extended psychosis and even death. I did an intervention with a colleague this last weekend on a 19-year-old, met with 25 members of his family, and he presents as though he is having a first break of schizophrenia. He's been smoking cannabis and using spice for about a year and a half, and it's almost impossible to tell whether this is a toxic result of the THC or whether he really has a first break of schizophrenia. Terrifying situation for the parents and absolutely avoidable. The use of marijuana is rising dramatically, particularly here in Colorado, and poses numerous health dangers, as my colleague, Dr. Riggs, will share with you next. Despite the current opinions of many, cannabis is second only to alcohol in vehicle accidents, which is something we don't hear about that much. A recent study showed that drivers who use cannabis within 3 hours of driving are nearly twice as likely to cause a vehicle collision. Cannabis smokers had a 10 times increase in car crash injuries compared with infrequent or non-users. And with the proper public awareness and passion, we might be able to inspire new THC-related legislation that not only impacts the safety of drivers that operate vehicles under the influence, but also protects everyone they share the road with. According to a recent post by the National Institute on Drug Abuse, NIDA, it's estimated that nearly 10% of people who use marijuana will become dependent on it. I have so many parents coming in to see me and saying, he's only smoking pot. I'm not worried. He's not using heroin. He's not on coke. Why should I care? Well, 18% of teens starting to use marijuana become dependent on it, and 25 to 50% of daily users become dependent or addicted. Parents should be worried. Preteens and adolescents are particularly at risk. The brain doesn't fully mature until 22 to 25 years of age. The bad news is that using before brain maturity can cause permanent abnormalities. The good news is that the earlier youth stop using, the more opportunity there is for the brain to heal. If we can stop our youth using until their brains are fully mature, they have very little chance of becoming addicted. And yet, of course, this is the age group that uses most. Marijuana can destroy the lives of youth for the long term, and our current dispensary system is severely flawed in allowing this to happen. Adolescents who used medical marijuana had an earlier age of regular marijuana use, more marijuana abuse and dependence symptoms, and more conduct disorder symptoms compared with those who didn't use medical marijuana. The earlier they used, the more severe the symptoms and the resultant behavior. I don't know whether you're familiar with the term dabbing. Dabbing is referred to as the crack of pot, as opposed to the crack of cocaine. It's the consumption of butane hash oil, BHO, which is an extremely potent marijuana concentrate that can exceed 80% THC content. Also known as dabs, honey oil, wax, shatter, or butter, its extraction involves packing a stainless steel tube with marijuana and blasting the tube with butane, an extraction solvent, which yields the potent concentrate and, according to FEMA, can result in explosions. The concentrate will also contain concentrated levels of any contaminants or pesticides that marijuana may have been exposed to. Let's not forget that inhaling impure butane is also potentially toxic. So let's take a quick look at the role of the family in risk. Teens who have seen their parents under the influence of mood-altering substances are at twice the risk of use. And between 2002 and 2007, almost 12% of United States children lived with a parent who's dependent on or abuses substances. And with or without genetic loading, early use is more common in families who use and more likely to result in addiction. The closer youths are to their families, their parents, the less likely they are to use. And those receiving alcohol or pot from their parents or taking it from home are most likely to be seen to use increased alcohol and other substances. So what can families do? What is our role as family members in prevention? I did a study on whether being connected to our family and culture of origin was protective. And connection is protection. A recent study in the journal Addiction showed that 42% of middle school kids were using drugs, but only 32% with strong maternal relationship or two parents at home, and under 17% of students with both strong relationships with their mothers and two parents at home reported substance abuse problems. So what my team and I did in this study was we looked at sexual risk-taking first and then compared it with other forms of drug use, including pot. And I'm just going to go through the sexual risk-taking study quickly. We looked at frequency of contact with extended family as protection with connection to family, and we looked at knowledge of family stories across time as a measure of connection to culture. We looked at women in a sexually transmitted disease clinic compared with women in a social community center. And both measures held up together and independently that the more stories the women knew, the more they saw their extended family, the less risk-taking. And then we went to adolescents, many of whom were also smoking pot or using drugs. Adolescents in a problem clinic. The least risk-taking related to, well, first of all, the measures of connection to family and connection to culture were the same, and they held up both independently and together. And then we looked at the themes of the stories. The children who knew mainly themes of resilience were the ones who took the least risks, whether it was with drugs or with sexual risk-taking. The next lowest risk correlated with themes of vulnerability, those who knew really horrendous stories of murder and addiction and suicide. The kids who took the most risks were those who knew no stories at all. We then analyzed the stories for their content and compared the themes of resilience with the themes of vulnerability. And we were absolutely amazed. The stories, the content itself, was often identical. And it was the way in which the family perceived the challenges they faced. Had they overcome them? Did they see themselves as surviving against impossible odds? Or did they see themselves as being overwhelmed and hopeless? So what families can do to prevent their youth from risky behavior is stay in regular contact with one another, share our intergenerational family stories, and share the stories of overcoming challenges, of our immigrant ancestors and what they survived, and how we are here today because of the pride we have in all those achievements of having survived, despite how difficult things were. So, what we can all do. According to a recent study, the relaxation of marijuana laws in Colorado has caused a significant spike in the number of young children treated for accidentally eating marijuana-laced cookies, candies, brownies, and beverages. In fact, one of my friends from Nepal, who's here at the moment with us, she and her young child nearly died accidentally eating what they thought were just cookies. As the floodgates open and the market is besieged with edible THC options like candy, cookies, and beverages, innocent children are at extreme risk. And as the laws change, studies like this will continue to reveal disturbing and harmful trends that the public and most pro-marijuana legislators haven't even begun to consider. And that's where the tragedy lies. This is a potentially deadly byproduct of relaxed marijuana laws, and if we don't get out in front of it and regulate packaging with child-proof technology, the fallout is likely to be disastrous. The extreme THC levels we are seeing in today's marijuana and related edibles are far too extreme for most adults. They're highly dangerous for children, especially when packaged in enticing ways that look like exciting candy and snacks. We're encouraging parents everywhere to be on extreme alert with regard to changing marijuana laws and the ultimate trickle-down effect those relaxed laws are having on innocent children. We cannot stop the potentially harmful trends and the irreparable damage caused by the drug, but we can certainly keep people informed and educated. We encourage each and every one of you to join us in being extremely cautious with regard to marijuana consumption based on the fact that in spite of its widening acceptance, it is still a highly addictive, potentially dangerous, and life-threatening drug when used irresponsibly, and particularly when mixed with unknown substances. Thank you.
Again, we'll have questions at the end. Our next speaker is Dr. Paula Riggs, child, adolescent, and addiction psychiatrist, professor and director of the Division of Substance Abuse at the University of Colorado School of Medicine. She's NIH federally funded clinical research in adolescence and substance abuse disorders and co-occurring mental health problems, and she's done this for nearly 2 decades. Dr. Riggs.
Over. All right. Thank you guys for, let's see, how do I pull my,
Click. Right-hand clicker.
my presentation? I don't see it on here. Okay, cool.
Is that you? Is that you?
Yes. So we just need to go back to the beginning.
Oh, let's go back.
Yeah, we'll start at the end. There we go. Presentation. There we go. All right. Thank you. All right, let's see if we can get this working. So I'm going to talk a little bit about the cannabis-related health. Are you signaling me or someone else? Oh. All right, so cannabis-related health and mental health risks. Just the science, that's all I'm going to report on, what's published in peer-reviewed journals, a little bit of an overview on the research on cannabis-related health, mental health risks, and then I'm going to take a developmental approach, so from prenatal all the way through adulthood, and then talk about some of the clinical implications that we might anticipate. So we could just start here. We know that both, certainly half of all psychiatric disorders start before the age of 15 and about 3/4 before the age of 24. So mental illness or mental health problems are largely pediatric onset in most cases. And most adults who suffer from any kind of addictive disorder, most began using when they were adolescents. So in a sense, these are pediatric onset. Both are pediatric onset, and they travel together. Mental health problems and substance use disorders travel together. And co-occurrence is the rule rather than the exception. So that's what science has shown us for at least the past 20 years of research. We also know from a recent national surveys done every year, this is from the Monitoring the Future High School Survey of high school students, 8th grade, 10th grade, and 12th graders. And we know that essentially what we can see from this slide, I don't know if my pointer is showing, but we can see that back in the 70s, we had a big peak, and we've not exceeded that peak again. And then you can see that through the 80s and through 93, we had a decline, an increase, and then a slight decline through the early part of 2000. And then for the past 5 or so years, we've had a rise and now kind of a little bit of a leveling off. It's a concerning increase in marijuana use amongst 8th graders in the green, the blue 10th graders, and then high school seniors, because we know that regular use, which is at least monthly use, and daily or near daily use amongst high school students is at 30-year peak levels. It hasn't exceeded the levels from the 60s late and 70s, but it's at 30-year peak levels. And at the same time, we know that the perception of regular use, perception of harm of regular use amongst adolescents, about 66% of adolescents think regular use of marijuana is no big deal, it's not very risky. That doesn't match up with the science. And every time you see a decrease in perceived harm, you see a concomitant and comparable increase in the rates. So we know that nationwide, we've seen kind of a chronic and a concerning increase in alcohol and illicit drug use, and particularly marijuana. But we know that in Colorado, we have rates that have exceeded that since we've relaxed medical marijuana legislation in 2009. We've seen our rates exceed the national rates in terms of marijuana use. In fact, there's some data data from, well, Healthy Kids Colorado. This is not the recent study. I guess the results are coming out next week for the most current study. But the study that went through 2011 showed that 61% of high school seniors in Denver had used in their lifetime, and that's certainly quite a bit higher than national rates. And we know that also throughout the state of Colorado, Denver rates are higher than Colorado in general, but Colorado and Denver are higher than national rates since 2009. So we're concerned about the impact of legalization, that there'll be even greater access and decreased perception of harm. So let's just go back to that developmental timeline, and I'll talk about prenatal exposure first. We know that, I'm going to talk a little bit about prenatal exposure, what we know about prenatal exposure, what kind of neurocognitive deficits arise from that. Dr. Landau spoke a little bit about what we were seeing in Colorado. It was published in JAMA in 2013, that a chart review of 500 charts from 2000, I think it was 2009 to 2011. Prior to 2009, they'd never seen a case of inadvertent marijuana exposure to edibles, and then there were 17 cases in that 2-year span. We've seen many more since then. And it's the seductive aspect of how you can't tell a gummy bear that has THC in it from a gummy bear that doesn't have THC in it. So we're going to see an increase in those kind of hospitalizations. What we don't have is research on the effects of secondhand smoke, and we really do need more research on that in households where there may be a lot of marijuana smoking in a state that's just legislated it. Oh, sorry about that. What happened? Here we go. And we're also going to talk about the neurotoxicity adolescent brain development. That's a real concern, and also a bit of I'll just say a word about neurocognitive deficits in adults who are heavy chronic users. In adults, it's not benign in the sense that it does cause neurocognitive deficits, impaired working memory, hard to convert short-term memory into long-term learning and memory, impulse control, decision-making, abstract reasoning, and verbal fluency. In heavy users who are adults, if they stop today, most of those neurocognitive deficits would resolve within 1 month, most of them. That's not so for adolescents. And as Dr. Landau mentioned, we know that adolescents seem to be more vulnerable to addiction, certainly to marijuana. That is, 1 in about 11 adults who experiments with marijuana will become addicted or dependent. 1 out of 6 adolescents who experiments will become dependent. And that's daily or near daily use when you're dependent. We also know that it has impacts on other systems. For example, decreases fertility, it disrupts menstrual cycles in women, decreases testosterone and sperm motility and quality in men. So it has other health effects as well. And I'd like to focus a little bit more now, drill down on the prenatal effects. We know that 1/3 of the THC that's smoked by the mother will cross the placental barrier and then affect the fetus. And it does interfere. It's pretty clear that the endocannabinoid system begins to develop mostly during 2nd, 3rd trimester, just a hair starting in the 1st trimester, and THC interferes with the development of that system. That system's important because that system regulates development of neurocognitive circuits and the circuits that are critically important to learning and memory. Neuronal connectivity, things like that. We know that we have 3 longitudinal studies. That means, following people over a long period of time, prenatal exposed and not prenatal exposed to marijuana. 2 of those studies are far along. That is, they've 14 years and at least 14 years follow-up from the Pittsburgh study and an Ottawa study. The findings are consistent across both of those studies, and I'll show you what some of those are. We know one study concluded that in utero exposure to cannabis, at least 1 joint or more per day, as the Pittsburgh study showed, can cause permanent neurobehavioral and cognitive impairments. I'm not sure if they're permanent, but they are certainly long-lasting. That is, let me just show you what it does. THC causes a miswiring of the fetal brain as it's developing. Essentially, I'll show you the next slide in 1 second. Basically, it binds to neurons that are developing, and what it does is the THC, when it binds out here, mostly are endocannabinoids called like anandamide. It tells the neuron where to grow to. when THC, marijuana is pregnant, is there in the neurons that are of a developing fetus, it starts growing different dendrites at different places, kind of a chaotic growth. And the neurite, the little baby neuron, the neurite doesn't know where to go. And so it causes serious disruptions in the connectivity of the fetal brain, we think. So essentially, that's prenatal exposure. Let's talk about the next slide, sorry about that. The neurotoxicity. We know that animal research shows, and we don't know this in humans yet, but it's concerning enough to be alert to it. That is, in animal research, there's evidence that prenatal exposure to marijuana in rat pups, for example, may kindle the brain in such a way it makes them more vulnerable to addiction to other substances later after they're born. We need research to find out if that's true in humans as well. We know that that babies or fetuses exposed to cannabis in utero have poorer self-regulation and sleep patterns in infancy, but they're really showing up learning deficits, memory deficits, reasoning skills, and some deficits in motor development by age 3. But what's more concerning is age 6 and through age 14, which is as long as they follow them, deficits in reading, visual analysis, inattention, hyperactivity, onset of depression by age 10. That's a big hit. That was a robust finding. And early onset of conduct disorder and substance use. In other words, there was poor academic achievement across the board, and we're going to really have to track this because 40% of new users in Colorado, at least the recent statistics I saw, are women, most of whom are in childbearing age, and so women especially need to be alert to this risk. This is a very complicated slide, also designed to make you kind of go crazy. But I want to give you a sense, and that'll probably show up in the reviews of this symposium. But basically, I wanted to give you a sense that this is a really complicated relationship between mental health problems and substance use disorders, particularly cannabis. That is, if you get depression by age 10, depressed teens have double the risk of developing a conduct disorder or kind of antisocial deviant behaviors. We also know that if you have a co-occurring mental illness or depression, ADHD, conduct disorder with your substance use, there's a much higher risk of high school dropout, poor academic achievement, and economic instability into adulthood. We also know that marijuana use, regular marijuana use during adolescence is associated with a doubling of risk of depression and anxiety disorder, not immediately, but in your early to mid-20s. So this is the research that is really concerning us as psychiatrists, child psychiatrists, and developmental and behavioral folks who are out in the community treating kids. Conduct disorder and academic problems double your risk of depression. So you see how one influences the other. No wonder they travel together. So let's just talk about the brain development for a minute. Why would cannabis be such a big deal and neurotoxic to adolescents during this period from about age 10 to well into your mid to late 20s? Their brain's undergoing rapid development. You're not getting a lot more neurons or cells. You have most of those by age 10. What's happening is synaptic pruning, where you're refining and making more efficient the circuits that are going to be really utilized, and you're kind of pruning away circuits that aren't. I'm going to oversimplify, so don't fault me for that, but basically, it's not as simple as use it or lose it, but it's sort of like you're pruning away circuits. Hey, do you think we're going to use these circuits for physics problems and piano lessons? No, we haven't used them yet. Am I out of time? Oh, I thought you were looking at me. See how paranoid I am? See, I've gone over before, people. So anyway, bottom line is, where was I, in fact? For God's sake, what? Yeah, oversimplify, you use it or lose it. You may prune away circuits that you don't want to prune away. And it matters what teenagers do. The environment and the predominant environment and activities that teens are involved in help shape their brain forever. That's the takeaway point. So let's get more specific about THC. How does it affect the brain? Well, here's how it affects the brain. THC, the active ingredient in most marijuana products, binds to the cannabis receptor we have in our brain. It's the cannabis 1 receptor. That receptor is critically involved in regulating the development of the business end of our brains, the prefrontal cortex. That's our executive functioning. You know, that's the area that slowly myelinates over time and gives us our more adult, abstract decision-making, executive decision-making. We can override some of those limbic drives. You know, I want it now. Well, maybe I should just put that in the savings account. If you want to wrap your head around what happens between age 10 to mid-20s, think of yourself at age 15, think of yourself at age 25, and pretty much that's what myelinating that circuit did for you. So that's a critical period of brain development. THC sitting on the cannabis receptor a lot of the time dysregulates, absolutely disrupts the development of glutamate pathways, the dopamine pathways, and all those neural connections that are happening in prefrontal cortex that gives us our abstract reasoning ability. So it's a problem. And the science is this. Regular use during adolescence. A study came out in 2012. It was a very well-publicized study, the Meyer study. And there are at least 2 or 3 other studies that corroborate these findings. That is regular use. And we're talking, okay, so daily, near daily, but as much as like 5 times a week use chronically during adolescent development can shave 6 to 8 points off their adult IQ. Doesn't look like you get it back. Now that is a big hit, if that's a permanent thing. Certainly causes lower academic achievement. Regular use of marijuana during adolescence quadruples the risk of psychosis. That's quadruples. That's a big deal. And it's associated with onset of depression and anxiety in early adulthood. So those are big hits, but let me just say there are 2 other, if that was the only study, we'd have to be suspicious and kind of worry, well, let's see if it's replicated. There were 2 other studies much earlier that hearkened this kind of message that is compared to controls. Pope in 2003 did a longitudinal study showing that those who start smoking marijuana before the age of 17 compared to after age 17 had persistent executive functioning and memory deficits that were out to age 27. Okay, and so Judith Brooke and colleagues did another study that shows that those who started smoking marijuana between 14 and age 22, but even those who stopped at age 22, still had neurocognitive deficits, not trivial ones, memory, decision-making, abstract reasoning, by age 27 compared to non-users or light users. So that's a pretty big deal. And let me just wrap your head around how big of a deal is this. I thought, well, why isn't this message penetrating when I do these public health symposia and all this? Like, people should be going, oh my God, 6 to 8 points off their IQ. That's 10 to 15% of our kids in high school using at that level, being exposed at that level. That's comparable to what the old literature in environmental lead exposure showed, 7.4 points off your IQ if you're exposed to 10 micrograms per deciliter of environmental lead. So we're kind of talking about something comparable. So just to kind of wrap up, we know that I've already made these points about the persistent neurocognitive deficits, why we're so concerned in adolescence, because we have, you know, if there was a neurotoxin in our air or the water that you knew, conservatively speaking, at least 50% of our kids are going to be exposed to, and 1 out of 6 of those are going to be exposed at a level that has been associated with those significant IQ reductions and persistent neurocognitive deficits. They're not going to go as far in life. We would pretty much be all over that as a public health issue, and that is what we're talking about. That is what we're talking about. So here's the other issue we have to face, and this has existed for my entire career and before I was born. So this is not about our legislation in Colorado, but it has always been true that fewer than 10% of adolescents who could benefit from drug treatment receive it. That's a horrible 90% treatment gap. If only 10% of cancer patients could get treatment, we'd be up in arms about it. But that's the state. That's what we're dealing with kids. Why is that true? Where are the 90% of kids who could benefit from treatment, that is, have a substance use disorder, but can't get it? There are high school students, and this has always been true. In other words, it's an artifact of our third-party payer system. Juvenile justice pays for most of the treatment, so you have to fall in that hole to get treatment in general. So it's been estimated by SAMHSA and other national surveys and data that 10 to 15% of high school seniors would meet diagnostic criteria for a cannabis use disorder or at least one substance use disorder. And yet they have very limited treatment options because they're not yet involved with juvenile justice. So let's just kind of wrap up and talk about the clinical and public health implications. What do we need to do as we try this new experiment in Colorado? What do we need to do to reduce the public health impacts and increase public awareness to make good decisions for ourselves? As Dr. Landau pointed out, the THC today is not your grandma's THC, right? It's very high potency, and it's probably associated with a higher addiction potential. Prenatal exposure, we've really got to get the message out to women, and women who are or may be pregnant should not consume this product. I think the science is there to support that. It should frankly be on our warning label. We've seen a big increase in first ever substance treatment admissions for cannabis treatment in adults. We're going to need more treatment capacity. We're seeing a sharp rise in emergency room visits and hospitalizations for cannabis-induced hyperemesis syndrome, delirium, and psychosis. So we're going to have to gear up there, and we really need to protect our kids. And I think for sure we're going to have to try to move treatment where it hasn't existed before, and that's get it into the schools. So those are the conclusions, and I thank you very much for your attention.
Great, thank you. Our next speaker is Dr. Ken Finn. Dr. Finn is board certified in physical medicine and rehabilitation, board certified in pain medicine, board certified in pain management, the exam council for the American Board of Pain Medicine. He's on the executive board of the American Board of Pain Medicine, and he also is on the Amendment 64 Task Force for Consumer Safety and Social Issues Working Group. So, ladies and gentlemen, Dr. Ken Finn.
Can you guys hear me all right? Yes. All right. Number one, I want to say thank you for taking time out of your day and coming to listen to me speak tonight. My voice is not as soothing as Dr. Landau's, so I apologize for that. But what I'm going to tell you, what I want to focus on in this presentation, 15 and 20 minutes really is not enough time to cover the broad topic of cannabis and marijuana. What I do want to focus on are some of the things that we do know and bring up a lot of the things we don't know that I would like people to think about. What we do know. There's a lot of science out there. There is actually very good science supporting the physiologic endocannabinoid system. We are very well aware of the CB1 and CB2 receptors, and we know that cannabis has its physiologic effect via the endocannabinoid system. This is not a chemistry class. I'm not going to bore you with a lot of the details. I think Dr. Riggs alluded to some of the neuroscience behind the endocannabinoid system. It's very complex, and it's real. The CB1 receptors are noted predominantly in the central nervous system, and certain components of that central nervous system have very different effects on our function, such as the basal ganglia motor activity, the cerebellum in balance and coordination, the hippocampus involved in short-term memory, the hypothalamus and appetite, limbic cortex and sedation, neocortex and thinking, and dorsal horn periaqueductal gray for pain, which I will get to shortly. There are other effects of cannabis in the brain, but again, it's very important to realize that the primary effects do involve the central nervous system. The CB2 receptors, which do have, they don't get as much notoriety, I believe, when the discussions of cannabis occur, but they are noted on the immune system cells and tissues and may modulate inflammation or immunosuppressive activity in areas of the body such as the spleen, tonsils, and thymus. Okay, we know about THC, the main commonly psychotropic component of cannabis, although there's a lot of other components that have been isolated from the cannabis sativa plant. Cannabidiol is getting a lot of press, particularly in intractable childhood seizures, but may have non or less psychotropic effects. We have endogenous cannabinoids, and the question is what other things may be out there. Physiologic effects are well documented in the medical literature. You have tachycardia, hypertension, vasoconstriction. But some of the other things that are coming out in peer-reviewed literature are acute coronary syndromes like myocardial infarction, atrial fibrillation, acute cerebrovascular syndrome such as cerebellar infarction, transient ischemic attacks and stroke, peripheral vascular ischemia, and for anybody who's an athlete out there, an impact on exercise performance. Pulmonary effects have been well documented in the literature as well, with large airway inflammation, bronchitis, increased airway resistance, lung hyperinflation, bronchial epithelial ciliary loss, which are the hairs that kind of keep the bad stuff out. The jury is still out as it relates to, similar with tobacco, on COPD, lung cancer, or effects on pulmonary function. There was a study about a year ago that demonstrated no impact on pulmonary function. Dr. Riggs alluded to some of the prenatal reproductive effects of use of cannabis in terms of fetal neurodevelopmental impairment, fetal growth impairment. And the question is there, with these longitudinal studies, whether or not there's going to be future psychological impairment. It appears that may be the case. There have been reports of stillbirths. There are reports of impaired spermatogenesis. I can tell you in Colorado Springs, my colleagues are noting a significant rise in THC-positive newborns. The data is not being very well tracked, at least in Colorado Springs. I don't know how it is being tracked in other hospital systems. I think the university system probably has a much better infrastructure to do that. But I think it's important data to track over time. Neurologically, the cannabis use can impair memory and cognition. It's documented in terms of reaction time, processing speeds, balance, coordination. I mean, you fail a roadside sobriety test and you do not blow more than a 0.08 BAC. Is there another impairment going on due to another substance? There are clearly neuropsychiatric effects, emotional effects, and structural changes within the brain itself that may be irreversible. There have been a lot of reports about areas of the brain that are smaller in size compared in those that are using cannabis compared to those that are not using cannabis. I sense that if other areas of the body became smaller in size, there may be less users out there. Pain is the world I live in. I'm a pain management physician. I try to take care of people that have pain conditions to the best of my ability. I did find this. I found it interesting. Water was on one of the natural top painkillers, which I don't typically recommend very often when somebody's hurting. But there's a lot of data about natural pain remedies that are available. And a lot of these, I'm sure you've heard the old wives' tales, you've heard, Epsom salts, et cetera, for muscle aches and pains, et cetera. But the pharmacology of cannabis as it relates to pain is extremely complex. And I think it's very important for those of you in the audience that are medical or maybe non-medical understand that there is science out there. I'm not going to stand here and pontificate that it's a bunch of horsewash and nothing is valid in terms as it relates to the use of cannabis in pain, but it affects me in my daily practice, and I'll get to some of those issues in a minute. We have the endogenous endocannabinoids. You have the CB1 and CB2 receptors, which are G protein coupled receptors, and again, we do understand a lot of that science. As it relates to supraspinal antinociception, which is basically the brain, on how it deals and processes pain in the body, there are certain components of the brain, like the VPL, or the ventral posterior lateral nucleus of the thalamus, the dorsolateral periaqueductal gray, the dorsal midbrain, the rostral ventromedial medulla, and the amygdala, which could explain some of the dissociative effects that people may get when they're using cannabis. You have spinal antinociception, which is at the spinal level, below the brain. The dorsal horn has been noted to demonstrate suppression of C fiber evoked responses. C fibers are neurons that come from the periphery into the central nervous system that modulate painful signals. Those receptors, the CB1 receptors, are noted on primary afferent neurons in the pre- and postsynaptic site. So they are there. We understand that. And then this peripheral antinociception at the dorsal root ganglion, where cannabinoid receptors are synthesized. They are noted on large myelinated and small unmyelinated cutaneous fibers, which I alluded to. They may have anti-inflammatory properties. There is some good science that they may show and demonstrate anti-inflammation properties. They suppress cytokine production. They may inhibit cell proliferation. And as it relates to neuropathic pain, they may have an effect on neuromodulation, which is a whole other discussion that we can get into. Currently, there's actually 61 ongoing studies related to marijuana and pain. 46% were related to neuropathic pain or nerve-related pain, HIV neuropathy, peripheral neuropathy, and then also cancer pain. Sativex and cannabidiol were typically the ones that are being studied, and only 13 out of those 61 studies, or 21%, were using what's most commonly utilized in Colorado for pain, are inhaled or ingested cannabis. So a very small number of current ongoing studies are actually studying what's most commonly used, which it doesn't make a lot of sense to me. This was a lovely picture that came out of one of the Denver dispensaries. But closer to home, you want to see that again? Okay, you want to stare, take a picture or something? Closer to home, as of April 30th, I mean, the most common, this was as of yesterday or a couple days ago, unless the most recent statistics were out there. There were been 258,000 new patient applications with 116,000 valid ID cards. 60% were men, and the average age was 42. So it's not the college guy or girl that are using marijuana across the state in the medical world. Where it hits me as a pain physician is that the vast majority, over almost 109,000 of those cardholders, are utilizing it for severe pain. Pain is a very, very broad topic. And I've tried to discuss this with the registry in terms of how can you break this out. If somebody has pain, is it because they had a rotator cuff repair? Do they have carpal tunnel syndrome? Do they have a backache? And they can't do that. Spasms were number 2. If you go to lower down on the list, cancer was a distant, almost last at 3% of the medical marijuana cards were utilized for cancer diagnosis. Obviously, this adds up to more than 100% because most marijuana recommendations carry more than one diagnosis. What we don't know, and what I want to just throw out at the audience is just for thought, there are lots of things that we don't know. What constitutes a medication? What is a dose of marijuana from a physician perspective? Are there hepatorenal effects that have been well documented? If somebody is on dialysis and using medical marijuana, do you have to change the dose like you would most other medications? Do we know all the details of potential long-term adverse health effects, like what I alluded to before in the cardiovascular or pulmonary system? Is there a relationship to cancer? I think it's way too early to tell. I think time will tell whether or not that is the case. There are issues regarding cell-mediated immunity. Do doctors get the education on different strains, potency, methods of ingestion, directions for use? I mean, what do doctors tell patients other than here's your card, go for it? Do they know whether, is smoked better, is vaporized better, is ingested better, or concentrates better? Where are the studies that show one is more superior to the other in whatever disease process may be occurring? There have been adverse and unexpected outcomes with the use of of marijuana. You know, these are some of the other issues about, you know, how do you monitor efficacy? I mean, if you're treating, I'm not a primary care doctor, I'm not an addiction specialist, I'm not an oncologist, I'm a pain management doctor, but when I have a patient that has a problem and I'm trying to manage that problem, I continue to follow that patient over time to document whether or not the treatment I'm recommending is benefiting the patient at all. You know, the law requires doctors to maintain good medical, they need a bona fide patient-physician relationship and maintain medical records. We're not sure if that's actually occurring or not, and if it is, to what degree. Do you allow patients to self-medicate? Do you allow them to titrate to effect? I mean, is that good medicine? The term of being couch locked, where you're so high you can't get off the couch, is very common in the cannabis world. Is there consistency on dosing for patients? And I'm not going to downplay the fact that we have huge problems with other things. We've got a huge problem with alcohol. We have a huge problem with narcotics. We have got a big problem with nicotine and tobacco. But in the opioid world, or narcotics, there's the physician drug monitoring program, which is very helpful for me as a physician to see if my patients are using things correctly and appropriately. If I have a patient that's getting narcotics from me and then getting narcotics from Dr. Smith, I can know about that. Oops, what did I do? So should they have a PDMP-like system? Because there is nothing to preclude any patient that gets a marijuana recommendation from a physician to go from one dispensary to the next and get their allotment of cannabis, and nobody will know about that. Vicarious liability. I had a nice discussion at COPIC about a year ago with the medical director, and brought up a lot of these things for physicians in particular. I mean, if you are recommending cannabis for a patient for a medical condition, should you have informed consent? Do these doctors go through the risks, the psychiatric risks of precipitating a psychotic event or schizophrenia? Do they go over the potential cardiovascular risks, the prenatal risks? You shouldn't use this while driving. You shouldn't use this while already? Holy crap. That went by fast. The law, one of my other colleagues that I present with is a traffic safety prosecutor for the state's district attorney's office. The law, the way I understand it, or he has explained it to me, because I'm not an attorney either, is that the law has been written to protect the patients that are receiving medical cannabis, and they are protecting the dispensaries, but they are not protecting the physicians that are making those recommendations. So if I make a recommendation for Mrs. Smith for medical marijuana, and Mrs. Smith runs over Mrs. Jones, Mr. Jones can come after me. Cannot go after the patient that ran over the other person, and cannot go after the dispensary. That's the way I understand it. So there are other medical legal issues that are now arising. I mean, what happens in the organ donor that is a heavy chronic user? Is that something that you would want to receive their heart from, or their lung from, or whatever? The unintentional exposures that we alluded to in the very young, or even now, I'm sure, that are occurring in the very old. There was a nursing home reported to have a pop brownie by accident, and several of the residents got ill. I mean, these are things that we haven't predicted and that are occurring in Colorado now. And we don't know about the long-term psychosocial sequelae. The effect of grow your own to 6 equals 6. You know, we hear people, I think people are trying to do the right thing, but we know there's a lot of people not doing the right thing. A lot of times 6 equals 100. Mildews and spores. Nobody talked about pesticides. I mean, drywall is not a good medium to grow crops. You know, people are growing them in apartments and houses. I mean, are there now going to be requirements for apartment owners for disclosure? Are there going to be insurance issues that are going to come down the pipe? The residuals in butane hash oil, I mean, there were actually, at this point in time, I was on the work group, there is no limit to the residual butane left in hash oil. So you will be inhaling lighter fluid if you're going to be smoking hash oil at unknown concentration and unknown health risk. So, and then the messaging to adolescents is becoming a big problem. And I think everybody, well, it's all about the kids. You know, it is about the kids because you know, in El Paso County, it's banned. Recreational marijuana is banned in El Paso County. Medical is allowed. And these vapor pens are showing up in our schools. Kids are getting expelled from school. They're having trouble with using cannabis despite all the things that we're trying to do to keep it out of their hands. I like this one. I did a bong, I did, a bong, a bong, I did. You know, this is Dr. Seuss. Cannabisized, I don't know how you want to say that. In summary, cannabis and its components have known physiologic effects. The details of those effects are not completely known and not fully understood. They may have detrimental health effects, some of which may be permanent. With widespread cannabis use comes a rise in the threat to public health due to many unknowns. We are already experiencing a negative sequela related directly and indirectly to the increased use of cannabis use. Public education and awareness is paramount. There may be use for components of cannabis to treat a broad spectrum of medical conditions. However, scientific study is so important to determine what risk-benefit, if any, is available, which is currently in line with many national organizations, including the American Society of Addiction Medicine, the AMA, and the American Academy of Pain Medicine. Thank you from Colorado Springs.
Wonderful. Our final speaker, and then we will take questions, is Ben Cort. Ben's passion for recovery, prevention, and harm reduction comes from his own struggle with substance abuse. Sober since June of 1996, Ben has been part of the recovery community in almost every way imaginable, from a recipient to a provider to a spokesperson. Cort has a deep understanding of the issues and a personal motivation to see the harmful effects of drug and alcohol abuse minimized. Until 2007, he was the HR director at an S&P 500 firm. Ben left this role to help start the Colorado-based Phoenix Multisport. While there, Ben worked extensively with the treatment community as well as drug courts and the therapy community as an advisor, a member of clinical teams, a frequent speaker, and liaison. Ben is on the board of directors of Project SAM, Smart Approaches to Marijuana, is a junior fellow at the University of Florida's Drug Policy Institute. He also serves on the board of directors for Denver-based Stout Street Foundation. And Ben now leads business development team for CeDAR. Ben Cort. That's you there.
Yeah. Thanks, man. Thanks, Bob. Oh, I'm going to have to lean over. You guys remember that show Quantum Leap, where he would like bounce into somebody's body and find himself in crazy situations? You might notice how Bob left off all of the letters that are not after my name. I'm sitting on a panel with a bunch of incredibly well-esteemed doctors, and this is kind of one of those how did you get there moments. So get ready for a massive, massive shift in gears. Can I use one of those hand mics? I can't. I'm going to have to come see Ken on Monday.
Do you want to lavalier?
This would be fun. Hello?
This is on.
Thanks, Bob. Okay, we'll do this. I'm going to really shift gears here. We've established the science. We understand these things now. And I'm going to move a whole lot more into what's really going on. So this debate for a very long time has raged on in the theoretical. Well, if this ever happened, then this would happen. And then we're past that now. We were onto the practical. What we've had, as this has moved into the practical, is very clear financial implications for certain groups of people to downplay certain parts of this and then to upplay other parts of this. So I think it's really important for those of us who are taking part in Colorado here in this great social experiment. The word, the phrase makes me a little bit frustrated because only 54% of our state consented to this experiment, and experiments are usually monitored by somebody, that we look at the practical now. So that's what I'm going to do. I'll move away from the science. I'll show you the stuff that's going on, and I think something that we have been saying for about 2 years, some of the work that I do with Sam. This is tobacco 2.0. It's why Bob's involved. I absolutely believe this, and I'm happy to engage with anybody who'd like to discuss that. It's also really interesting that when you put something like this on and you get a bunch of doctors together and then a non-doctor together who's just paying attention, I'm really glad that all of you guys are here, but if this would have been a cannabis industry gathering, we'd have every member of the local media and plenty of national media back here, because it's good TV. Good science doesn't always make good TV, but it's our responsibility to know it and then to get that word out there. So let's look at a little bit about what's going on. I mean this stuff, what I say about Sam. When they asked me to get involved with Sam, I am no drug crusader. I'm a recovering drug addict myself. So that means that I'm the last guy in the world who can ever cast a stone. And I also work in treatment. And I work in treatment not because the money's the greatest thing in the world. It's because I love helping people who have addictions. That's why I'm doing this. So when they said get involved, not really my bag, man. And then they started talking about what they wanted to do, was to have an honest conversation, was to allow science to inform the way that we were going to build public policy, and to promote research of marijuana's medicinal properties. I really think that's important. I also think that it's really important that we never put low-level users in jail. And I'm glad that we do very, very little of that in America right now. But I think it'd be great if we did none of it. So, that was Sam. Smoke a fresh cigarette. Can you guys all see Dr. Finn right here doing no, because this is crazy, but this is a real ad. The slide deck that I took this from, I had a ton of these ads, actually, and I pulled them out because I knew we were going to have to go quick. We have to go quick. So you got this. This is good stuff, guys. Get involved in it. Whereas the give your throat a vacation. I love this. This is 1994. This is not 1954. Okay, this is 1994. All these guys coming out saying, well, cigarettes are not addictive. Prove it. You can't say they are. Look, we got this study and this study and this study. They had a lot of non-peer-reviewed, industry-funded studies, was what they had. I really appreciated my much more distinguished panelists up here highlighting the difference between a peer-reviewed study and a non-peer-reviewed study. Very important things. In fact, I read something today on the Cannabis, I'm a daily reader, that said the jury's still really out whether smoking marijuana while you nurse is a bad thing. Because there's 58 studies that say that it is, and there's about 45 that say that it isn't. And we'd really love to see who published the 45 who said that it isn't, because actually the jury's not out on that one. You don't want to do it. This is 1964, the American Medical Association. Cigarette smoking is a serious health hazard. That's when this ad was published. More doctors smoke Camels than any other cigarette. That's a 1964 advertisement for Camel cigarettes. This is the don't you wish we'd have listened to the AMA? This is the AMA last year. Cannabis is a dangerous drug and as such is a public health concern. The sale of cannabis should not be legalized. Well, oops. This is a fabrication. You guys have seen this all over the place, right? People put this up to scare folks. This is the kind of thing that we threw out to kind of, that's not real. Some guy did this in his Photoshop thing. That was kind of funny. It scared us. We thought, my goodness, big tobacco might actually take over. Or if not take over, it's going to be the same thing. That's not a fabrication. Now, these guys, this is a decent sampling of some of the pre-rolled cigarettes that have marijuana in them that are out there. There's about 15 companies manufacturing pre-rolled cigarettes. And this is not fake. The Cranford's actually is a Colorado-based company, and they started about 3 months ago, and it looks like they're on track to do about $100 million this year. I love this one. Do not drive or operate heavy machinery. Keep out of reach of children. Unlawful to redistribute. See, I couldn't even have read their slides, let alone done them. But you can't distribute them, but let's put them all in pack of 20 really nicely rolled, ready to pull out, kind of things. The Yale MBAs are here. Guys, don't miss this stuff. And don't let the industry shape the way that we think about this stuff, because this is real. The guys who are leading this is not the normal of the 1970s. This is not the tie-dyed, ponytailed, everybody needs to get high, man. In fact, a lot of those guys are really frustrated with the people who are taking over the cannabis industry right now because it's all about the money. Well, you're damn straight it's all about the money. This is America, and that's how it works. This is the cover of Fortune magazine, not a fabrication, real stuff. Here's a direct quote that I added to the cover from Troy Dayton, who founded ArcView. We have 250 high net worth accredited investors, which places us in the top 10 for all angel investor groups, not just cannabis. It's cannabis-specific angel investor fund. Crazy that they have those. Well, they also have three VC groups. They have one full-time K Street lobbyist in Washington, D.C., 20 full-time lobbyists here in Colorado, and, oh, there was the Wall Street Journal. This gentleman actually publicly describes himself frequently, Google his name, Justin Hartfield, he's made about $100 million with this Weed Maps app, as the Philip Morris of pot. He needs a PR guy. Here's the ArcView group showing you what's happened this year. You think that's crazy about the money and the lobby and the everything and the... Here's a real quick sampling of some of the industry groups that are out there. The National Cannabis Industry Association. This is not small-time stuff. There's small-time shops around there for sure, but the lobby is not small. So what happens is you get a substance like this that we were convinced for a while there's nothing wrong with it. It's just weed, it's just weed, it's just weed. Less harmful than alcohol. What's that even mean? Just weed, just weed, just weed. You get the money behind it, gets really, really, really hard to regulate these guys. You know, we haven't increased taxes on alcohol in 35 years, not because we don't need more money to combat the negative effects of alcohol, but because they got a really, really awesome lobby. These guys, the MPP, the DPA, and NORML, have $100 million in the bank between the three of them. And they're spending it. MPP and NORML are just weed specific. The DPA is actually their stated goal. You're welcome to read it directly on the website. I think I might have a quote from Nadelman at the end here, is the legalization and the free market of every substance on the planet. That absolutely includes heroin and meth for these guys. But we're sticking to weed. Youth use, really big deal. I'm talking Colorado now. I love this Nintendo controller. Okay, we covered this. 1 in 6 kids, youth use, bad. Marijuana is addictive. We know they covered that, right? I don't need to get into this. For the first time ever, the DSM-5, you all know what that is, clearly spells out the objective criteria for addiction and cannabis withdrawal, which is actually really interesting. People ask me all the time, cannabis can't really be addictive, man. It can't. Well, this is not a subjective thing. We don't walk around inside of the treatment community, inside of the addiction medicine community and say, addicted, not addicted, addicted, not addicted, addicted. It's objective criteria. You meet it, you don't. This, I'm going to get into the pictures now. Even when I show these in Colorado, sometimes people get a little worked up. These are all pictures from Colorado. But let's preface this by Amanda, whatever her last name is, Raymond. I actually debated her once, and she was interesting. She said, I really see the future of the marijuana industry being way more like wine than beer. She goes on to say, sophisticated. Paula, you okay over there? Nobody takes me seriously. Sophisticated. This is adults. These are connoisseurs. We won't stoop that low. My goodness, we've learned so many lessons from the beer industry. We will regulate this. We even put nice regulations onto the books. What we forgot to do was build the infrastructure to actually enforce the things that we put on the books. Let's keep it classy, Colorado. 20% off with student ID. Fred Flintstone, that's not weed. That's not marijuana in its traditional form. That's a dab. Yabba dabba doo. Smoking a dab between two half-naked chicks. Look, they got tattoo artists there that day. Here's another cartoon character. Keep it classy, Colorado. It's a 3/4 page full color ad in the Denver Post. I took this picture on my phone. It's why it's blurry, because I used to read the Post every day. And this was, I'm sitting at the table, and my 7-year-old's right here, and I flip the page. The page goes like this. Whoa, Dad, who's that dude? That quick. Why? Because The big cartoon joint with the half-closed eyes and the skyline of Denver with the weed in it is not built to appeal to me. It is built to appeal to my 7-year-old kid. Argue that with me. I called the Denver Post. Greg Moore wasn't too impressed. I wrote a letter to the editor. I don't know how it didn't get printed. I used really little words. I'm sure you can get. This is the Denver Post's main website, and I got a quick screenshot. Prior to getting this screenshot, this was on 420, there's a pop-up ad that stayed up for 15 seconds. I reloaded it a couple times to make sure it would happen every time, for a dispensary. Stayed up for 15 seconds just advertising a dispensary. And then you could get through it, and then you could get to the news, the objective news. Celebrate the first inaugural Front Range. Here's an ad for a dispensary. Here's an ad for a dispensary. There we go. There we go. Be safe. Be responsible. Be awesome, Colorado. That's the Denver Post. If you had any questions about how to force butane and highly compress it through those glass tubes to squeeze the THC out of it so that you could make concentrates, the thing that's seen us admit, I think, almost 20 patients into our burn unit this year. If you had any questions on how to do that, thankfully, the Denver Post had a YouTube video that they posted online for about 3 weeks with a step-by-step and a guy showing you just how to do it. So, thanks, guys. Let's keep it classy. There's $1 joint when you show your ski pass. So it's illegal to smoke your weed on night. We can't even go there. New products. This is fun. Fun. Concentrates. This is the Rolling Stone said, concentrates get you really, really high. I have to move faster. You hear this all the time. It's just a plant, man. George Washington smoked it. It's been around for thousands of years. It's just a plant. Genesis 1:12. I quoted this to my dad all the time when I was getting high because he was a preacher. I've given you all the seed-bearing plants and herbs to use. They mean weed, man. This is not just a plant. This is an 80 to 90% THC product that's probably accounting for roughly 30% of all of the retail sales in Colorado. Lots of people are initiating on this stuff now. High Times, this was awesome. With dabs, this actually printed in that magazine. You can see it, May 7th. With dabs, your local Action News team gets to do a marijuana story that shows crack pipe torches used on sticky heroin-looking goo made from a process that blows up like meth labs. High Times said that. And they said, so this is a real PR thing, people. Chill out a little bit. Yep, that's what happens. Let's talk about smoked marijuana in Colorado. We got the best weed on earth. 20 to 30% THC in our smoked form. Naturally occurring inside of cannabis is about 0.2%. That's what George Washington sat on his porch and smoked and wrote that famous letter home about. That's what was going on back in the day. 20 to 30% is past good botany. It's really, really good chemistry. This is awesome. 1960, ending in 2011. I'm sorry that the bottom's weird. I'm not good with PowerPoint. Here's what happened with THC inside of marijuana over these 50 years. CBD, which, as Ken told us, has actually got some pretty interesting things we might consider for pain management and other things in it, stayed relatively flat. This ends in 2011. National average using the marijuana they collect at the University of Mississippi. Here's Colorado. 4 years. The increments here are 5. Okay. Edibles. This is important. There's no limit on where THC can be put, and I'll show you that. This is a dispensary right here in Aurora, as a matter of fact. Check out the bottom of this. I dig it. But people drink less, though. Well, there's your Smirnoff, there's your Budweiser, there's your next to your lollipops and your fish and your candy bars and your can of butter. That's one of the reasons why this is in everything. Because you can use this super potent stuff to make your edibles with. That's why it's gotten so much easier to manufacture edibles. Yep. Here's one of my favorite things. These sodas down here, Dixie Elixirs. These guys, Colorado-based company, they're going to do $1 billion this year. There's 2 Colorado-based companies that'll do $1 billion, Dixie Elixir and Open Vape. There's 10, per Colorado law, there's 10 servings of THC in that carbonated pop-top fruit-flavored beverage. 100 milligrams of THC, you can only have 10. This is the famous Chuba Chew. Well, there it is, unwrapped. There it is, wrapped. This is what the gentleman ate. Forget it. Bad thing. It's what the guy ate before he shot his wife, and they think that it's probably pretty similar. Read about it yourself. I'm not going to talk about their business. 100 milligrams of THC inside of this. You're supposed to cut it into tenths to be in compliance with Colorado law. Silly, right? Who's enforcing it? Same people who are not enforcing can't sell weed after 9. Well, we have round-the-clock delivery now. We have takeout. Can't do that. It's totally illegal. Can't put advertisements. These gummy bears, 40 milligrams of THC inside of these gummy bears. Just nibble an ear. Medical cotton candy. Pot suckers. Fish. These look awesome. 100 milligrams, up to 150 milligrams in candy bars inside of Colorado. This is just the reality of it. And then they advertise it in those ways that I showed you. That's good. A 2-year-old girl 2 miles up the street from my house who ate a cookie that she found on the ground, according to her mother, on January 3rd of this year and ended up in the ER, probably didn't know that it had 8 servings in it and you had to cut it into 8s because they're so potent. Thank you, can of butter. Vaping now will run. Look, Groupons for vaporizers that are for just weed. Groupons. Here's some of the different vaporizers we have. We have big issues with these things. This is the scary one. These guys started it. Lots of people are doing it now. You can smoke buds, flowers, concentrates in a wax form or in a hardened form, all in this beautiful thing right here. How we're smart. And Japan Tobacco International, JTI, is the 3rd largest tobacco conglomerate in the world. They just bought a huge stake in one of the biggest marijuana vaporizing companies that's out there. E-cigs bad. So what are our choices? Go with what everybody said, legalize it all, industrialize, commercialize, or throw everybody in prison. I will reject that false dichotomy. I will encourage you to reject that and to say it is not an all or nothing. Legalization is what we were sold. Industrialization and commercialization is what we have gotten. Don't put people in jail. I'm with you. Don't sell this stuff to my kids aggressively using cartoon characters and throwing 90% THC into it. I'm done, so we get a few minutes for questions. Thank you very much.
So why don't you keep that one? Is this working now? Can you hear me? Yep, good. So I'll take, do you guys have a microphone there? All right, this one. So questions, we have time for questions. So let me, if you could, when you state your question, if it's directed to a particular panelist, let me leave this up there for you.
I have one.
This work? Does this? Hold it. Should work. Work. Okay.
This is for anyone who wants to answer it.
Let me just.
We
here.
need a live mic for you.
Hold on.
Can you hear me now? No. Okay. This is for anyone who wants to answer it. What do you say to a teenager who's using regularly and keeps screaming, it's natural, it's only weed, it's only weed, it's only weed, it's not addictive, and you know they're addicted to it, and you just can't get through to them. Any suggestions?
Do you want to do that?
Well, you're right. I've treated adolescents for 20 years in this town. Can be tough to get through to them. But most of the adolescents are kind of set up when you talk about the brain. It's like I've been involved in implementing an evidence-based substance treatment in a high school, Adams City High School. It's beyond conscionable that we don't even have it in our high schools, but Liz was the first one. Every kid referred for a drug or alcohol school offense. every one of them agreed to go into our treatment. They go, I totally have. Now, if you're a mom, the parent, but usually they'll come in and say, I know, everybody, I'm saying to the kid, I know everybody thinks this is a benign recreational drug. What's the big deal? Like it's an herb, right? And I said, the science shows the levels you're using at every day. Some of these kids were in high school. They're not in juvenile justice. They're not court mandated. They're using 2 grams of marijuana a day, and on the weekends 6 to 8 grams. I don't even know how they stand up. That's just your average high school student referred for a drug, or they're caught at school with it. So I said the level you're using at shaves like 6 to 8 points off your adult IQ. And I have to say, so some kids it won't impact, but this particular kid that I told that to, he came in the next week. He told the counselor, I don't need treatment anymore. She said, why? He said, because Dr. Riggs told me she shaved 6 to 8 points off my IQ. I want to go to business school. I'm going to need the 6 to 8 points. So kids do get impacted, and it does go in if you're credible and you stick with the science. You can't over-exaggerate. You can't put a picture of a fried egg. This is your brain on fried. You got to stick with the science. You're credible, and what it doesn't do, and that really helps. But I know they're tough because I've been doing it for 20 years.
Yeah, I feel exactly the same way. One of the things that I find really helps is meeting with the whole family at once and showing them slides of what things look like. A young kid, an adolescent smoking pot only 3 to 4 times a week for 3 to 4 years. When you look at a functional picture of the brain, showing what parts of the brain are functioning and which aren't, it looks almost identical to an adult who's had a stroke. There's so much of the brain that isn't lit, that isn't showing function. And that terrifies them. And then it's also a question of talking with them about their future, as Dr. Riggs was saying, and talking about what the alternatives are. Because a lot of the difficulty in school is that that's what everybody's doing. Well, do you want to be like everybody? Do you want to have problems with your brain? What are your long-term hopes and dreams? And then how can we as a family help? What can we do to offer alternatives? And there's some amazing alternatives. Ben Cort spoke about Phoenix Multisport. There are a lot of different kinds of activities for teens that allow them to test their bodies and their minds and show them that there are healthier ways to have communal recreation without being with a group that is smoking.
Could I just say a follow-up point to that? That is one of the most robust resilience factors that has shown up in every longitudinal study that we have. That is, one thing you can do without being a professional, a treatment professional, is at any stage of the game is involvement in enjoyable activities that are non-drug, pro-social, incompatible with drug use, preferably if they have pro-social adult role models, non-using peers, and they give the kid an opportunity to get lots of, accolades and self-efficacy. Like, that's why we have our karate grant. We had a martial arts grant because pro-social adult role models, peers who aren't using, you get a trophy every 5 seconds in karate, right? I mean, whatever you do. and you can be in it your whole life. It's gender friendly. So those kinds of activities, that's a protective thing that one can do. But treatment really helps. It's not for just parents to do your best, but there really is treatment that works. And so if they're in trouble, get them to treatment.
Let's take next question. Who has another question? Question? Yeah.
Hello, my name is Lauren Hughes, and I'm licensed professional counselor and licensed addiction counselor. So,
Sorry, can you hold the mic a little closer?
Yes, I'm sorry. Can you hear me?
Yeah.
That's better.
My question is similar to yours, where I work with your kiddo or whoever you're talking about. I'm a counselor, and I mainly work with adolescents who are struggling with addiction. So what I want and would be very helpful is your guys' slides, because I sit down with the family, or for example, the slide you just spoke of with the brain. I would love to have a slide like that because I'm not a medical doctor, and I refer to medical doctors. So for me, my question is, how can I have access to a slide that you're speaking about when working with families? I do have material, but that's
absolutely. If you go onto drugabuse.gov, drugabuse.com, drugabuse.gov, which is the NIDA website, the National Institute on Drug Abuse website, drugabuse.gov, G-O-V. They have wonderful slides on marijuana showing all the slides that we use for families, for educating schools, about exactly what happens to the brain, exactly what happens to, the prefrontal cortex. Dr. Riggs was talking about brain development. We both were. You've all been around, who hasn't been around a little infant who, when you clap your hands, goes like this? That's because our babies don't have myelin yet. So the myelin, if we want to talk in everyday terms, is like the plastic coating around an electrical wire. That myelin is not complete until the age of 22 to 25. So if you have kids experiencing things like pot prior to the myelin being intact, we're damaging the brain. And you can see pictures of what happens to the brain and how the function is impaired. And the parts of the brain that are impaired are the ones that are responsible for higher function, the things that adolescents already don't have, like patience, tolerance, impulse control, logical thinking. So you're damaging that even further. And they want to be able to have those because they want to achieve something. So you tap into their desires for the future and show them how this moment in time is not worth wasting.
Let's take one or two more questions, and then panelists will be around for questions after. Are there any more questions? Or, oh, okay. Get my cardiovascular working.
Thanks very much. I just wanted to ask, does the brain repair itself, and how long, so when somebody stops using, and how long does it take?
Does the brain repair itself, and if so, how long does it take?
We don't know the answer to that. So just to be very clear and honest about it, so it depends on, how long the regular use, how old were they when they started using, et cetera, et cetera. We do have pretty plastic brains. I mean, we have brains that develop, and they continue to develop, and it's not true that we never get any new neurons, and when we're adults, we do with new learning. None of that's true, but we don't know. If you're exposed in for fetal development, it may cause lasting effects. In adolescence, there may be permanent effects. There may be ways that there's evidence that the brain gets around some of those defects. You may recruit other parts of the brain to do the same kind of problem solving. So to heal itself, though we don't know the answer to what you're talking about. But the fact is that kids, who were abstinent, even used regularly during adolescence, became abstinent at 22. That was the Brooks study. They still had neurocognitive deficits at age 27. Now, do we have any therapies that if we really worked with them, could we help them regain those deficits? We don't really know the answer to it, but naturalistic on their own, it looks like some of the damage may be permanent. So we don't know the answer to that. How long or
okay. Any question? One more question, if there's one more question before we wrap up. Do I see one? Okay. Well, let's thank our panelists for an excellent presentation. And I'm sure they'll stick around for questions if you'd like to ask some questions. Thanks so much for coming.